REDQI is and a little bit about what implementation was. So really through our projects, our overarching goal was to enable the health system to deliver equitable services to all. And as Fussam was saying, we recognize the need reaffirmed by Gavi 5.0 and WHO IA's 2030 strategies to focus on equity in immunization. And really what this meant to us was implementing approaches that focused on improving equity to leave no one behind, tailoring strategies to reach missed communities, and working towards resilient, integrated primary healthcare systems. So next slide, please. So in Ethiopia, the UIFHS project, which was funded by the Bill and Melinda Gates Foundation, designed and implemented the REDQI approach in equity settings, really focused on both rural, remote, and nomadic or more fragile settings, weak health infrastructure, to first establish the functionality of the RI system and then build on fundamentals to improve the quality of that system. This slide shows the evolution of our project, starting as a pilot in 3 districts in that first map in 2011, and then scaling to over 100 districts and 2,700 health facilities by 2018. Next slide. In Uganda, JSI supported implementation of REDQI through 2 projects. One was the Bill and Melinda Gates Foundation funded SS for RI project. And the second was the USAID funded maternal and child survival program, and collectively worked across 5 regions, 25 districts, and 750 health facilities. So in both countries, really reaching a significant scale. Next slide, please. So what is REDQI, you may be asking? And Fussam very eloquently explained what RED is and how important the strategy is. It's a widely used approach to strengthen management of immunization services at district level or below. And the RED strategy has 5 main components, which are there outlined on the left, and is the national strategy implemented in both Ethiopia and Uganda. REDQI is an innovation that applies concepts and tools from QI to strengthen the quality of management. The approach is designed to help health managers work at district, sub-district, and facility level to put RED into place. So then why add quality improvement to RED? In our experience, we found that districts may excel in one component of RED, for example, planning for immunization services, but then fall short in strategies to engage the community and then actually reach them with services. So RED focuses on what is needed to improve performance, but QI is focused on how, the process of problem analysis, prioritization, and seeking local solutions. And so building these skills in problem analysis, prioritizing activities, and the ability to be adaptive and problem solve are more critical now than ever, as our EPI managers and health staff are facing multiple challenges. They're having to deal with COVID-19 vaccination rollout, designing and ensuring catch-up vaccinations are provided to those who may have missed vaccinations, and they're also working to maintain and build RI services, and not just for infants, but now across the life course. Next slide, please. So as we've described, our focus has been on building the capacity of health managers and staff to plan, implement, and monitor routine immunization services for all populations, with a focus on underserved and underreached communities. This slide provides an overview of how REDQI activities enhance each of the 5 RED components. So I won't go through all 5 of them here for you. You can read them at your leisure, but as an example, for planning and management of resources, we support health systems to use data to identify RI system problems. Then, for example, as part of the micro-planning process, we use a quality improvement tool, the fishbone analysis, to break down the problems, to get at the root causes, and then test locally feasible solutions through the use of Plan, Do, Study, Act, or PDSA cycles. So that's just one example of how QI tools enhance one component of the RED approach. Next slide. For those unfamiliar with some of the QI approaches I've just been mentioning, I'll touch on them just for a minute. So we support the establishment of quality improvement teams. You see the picture right at the left. At the health facility level, great, thank you. At the health facility level, this includes community members, and at the district level, civil administration. And these groups help to identify, analyze, and propose solutions to problems, and then test ideas. So for example, at the health facility level, the quality improvement team may look at their coverage data and see that Penta 1 coverage is low. So they will then do a root cause analysis, which is the fishbone, which is right here in the middle, to identify why coverage is low, determine a main cause, and then develop a plan of action to address that cause. And that's when they'll use the PDSA cycle. So for example, let's say Penta 1 coverage is low because we're not tracking pregnant women in new births. So we set up a mechanism with the community to track pregnant women, report our own births, and then encourage them to come for immunization. Next slide. So I've spent some time describing what the REDQI approach is, so hopefully everyone has a good understanding of the approach. I'll take a moment just to explain its introduction and implementation in districts. So REDQI was implemented in both countries through a 3-step process. It typically was conducted over a 20-month period. The first 2 months were introduction, followed by about 12 to 13 months of technical assistance, really focused on training, on-job support to really build foundational skills and get and institutionalize these processes. And then the final few months focused on helping districts and health facilities really take over complete ownership of the approach. I'll also note that we've put together a guidance document for immunization managers who want to implement REDQI in their countries. And this 3-step process is provided in much greater detail there. And in addition, we're developing an e-learning course to support introduction of the approach in new contexts. So we'll have that as well. Next slide, please. As you can imagine, the 2 projects have collected a wealth of information and learning over the past decade. And so in an effort to synthesize and package learning from the projects, we received funding from the Bill and Melinda Gates Foundation for a REDQI assessment, which was led by our independent consultant, Steve Stewart, who's going to follow this slide. And really the purpose of this REDQI assessment was to draw out lessons learned, particularly on the scale up of the approach, and to then use this information to inform how the approach could be tailored and packaged for introduction in other contexts. So I'm going to now turn this over to Steve, who will walk you through the assessment methodology and some of the main findings from that. Hand it over to you, Steve.
Sorry, thanks very much, Lisa. I was on mute. Could we go to the next slide, please? So good morning, good afternoon, and good evening to everyone. It's a real pleasure to be here with you. I want to leave as much time as possible for the panel discussion. So I've got about 10 slides or so to go through, but we'll go through them really quite quickly. Start with the methods that we used to do the assessment. We did a desk review of a lot of the existing program documentation from the 8 to 10 years of implementation that was done in the 2 countries. In addition to that, we did a series of key informant interviews with 28 folks in both Ethiopia and Uganda, people who were familiar with the implementation of the approach in the 2 countries. And these are people like national immunization officers, district health facility EPI managers, immunization partners, and the project officers from JSI. So those are the methods that we used. Next slide, please. And just to look very quickly at some of the results. For example, we wanted to really look at, was this an effective intervention? Was it considered to be? And so we had a wealth of both quantitative and qualitative data, but specifically just some selected data from Ethiopia. We saw districts with completed microplans really jumping from 14 to up to 89% across 84 districts. defaulter tracking mechanisms increasing from 63 to 89% at the lowest service delivery level, the health post level. More consistent Penta-3 reporting across all the tools, it more than doubled from 42 to 90%. And this is a capacity building project or approach, I should say. And it's often difficult to link quite directly capacity building with actual increase in protection against VPDs. But here in Ethiopia, there were serological surveys that were done before and after the approach was implemented in the pilot districts. And what they saw was that the number of children protected against tetanus rose by an average of 12% across those 3 districts. And children protected against measles rose by an average of 14% across those same 3 districts. So that's really important data to kind of highlight in terms of the link between the approach and actual protection against a VPD. Next slide, please. In Uganda, again, just some selected data. A 5-fold increase in updated microplans across 248 facilities. And importantly, really, a 42% increase in the number of communities reached with immunization services across 10 districts. In a couple of districts, the number of routine immunization sessions conducted more than doubled. And fewer data discrepancies were seen in what was recorded in the child register and tally sheets. We saw a real drop in those discrepancies. Okay, next slide, please. So we asked during the key informant interviews, what do you consider to be the most useful or valuable QI tools and practices? And here is the quick list of the top 5. People really, again, in the 2 countries, participatory mapping, bottom-up microplanning were seen as very important, particularly because they involved community members and local officials and elected officials who participated in those activities. Capacity building methods that were involved things like mentoring and a non-punitive approach in supportive supervision. The problem-solving tools that Lisa mentioned just a moment ago, and also leadership management and accountability training that was done in Uganda. Next slide, please. Won't touch on this very much, but just to note, one reason that a lot of approaches or interventions don't expand to other countries is because they're considered to be expensive and difficult to bring in because of that aspect. It's interesting that all the key informants that we talked to, all 28 in the 2 countries, all said that they considered the REDQI approach, that the cost of it was really low. And the 3 sort of top reasons are listed there. Not needing to purchase extra equipment, enable staff to improve on already practiced activities like microplanning and supportive supervision, and it's really embedded and integrated into the existing health system. Next slide, please. So there were numerous lessons that were learned, sort of the look back that we can say, but also even during the intervention itself. Just a few things to touch on quickly. Lisa mentioned that the period of support and introduction and support is typically around 20 or up to 24 months. Initially it was 13 months, but they saw that additional time was needed to really embed those practices into districts and facilities. And finally, I'll just jump to the last one, just for time's sake. It's interesting that the QI tools and practices were seen very quickly that they could be used and expanded beyond simply the immunization program. That's where JSI introduced them, again with bottom-up microplanning, community engagement, problem-solving tools. But those staff who typically run not only or operate in not only immunization programs, but other public health programs, they saw the utility of those tools and started applying them in things like family planning, antenatal care, nutrition, HIV prevention services. So the value of those tools and practices could be used certainly beyond the immunization alone. Next slide, please. Okay, I'll pass through this very quickly. This is the topic: engaging with non-health stakeholders in planning and monitoring immunization programs. This will be the main topic of the next discussion series a week from today that Rebecca Fields and a panel of people will focus on. Just to highlight one thing though, the results or the benefits that accrued from this practice. Improved buy-in and local ownership of the immunization program. Importantly, really, more accurate target population estimates. And also, equally important, increased number of outreach sessions that were planned as a result of this. Local resources being identified to support EPI services and improved EPI service delivery overall. Okay, again, next week, if you're able to, please join that session. Again, the focus will be on this aspect specifically. Next slide, please. Okay, so just to go through the key lessons overall that we're seeing. Again, the approach viewed or perceived by those who implemented it as being valuable, effective, inexpensive, compatible with existing systems, and importantly, sustainable. We've touched on the quantitative findings already, so we'll go to the next slide, please. This is interesting, and we heard it from people working in both countries. There's this operating principle that the intervention or that the approach had of the way it was implemented, that there was ongoing learning, that there was flexibility in the approach, and that there was a real open-mindedness about making changes and adapting as needed locally. Adaptations were really the result of openness to learning and not becoming a prisoner of your own original ideas. It's actually a theme that could be applied to life as well as an approach like this. So that openness led to an improved intervention, people felt. Touched on the engagement with non-health stakeholders already. More to come next week on that. Next slide, please. Sorry, I think the other way. Yep. The approach start again. Capacity building programs often feel that once people are trained or they learn a practice, that it will be sustained. We know in actual practice that is only part of what's needed. So the approach tried to work in multiple ways to ensure some sustainability. So integrating the approach with existing practices we talked about already. Significantly, really tailoring the approach to the local context. For example, lightening certain activities in nomadic areas or places that had weak health infrastructure. It was not a cookie cutter approach, but it was really tailored to what the local context was. Finally, institutionalizing the approach, working closely with the Ministry of Health to include QI tools and practices in EPI guidelines nationally. Next slide, please. And just coming to an end here, the close partnership between JSI and the ministry was really seen as being effective in helping the ministry feel great ownership of the approach itself. That was achieved by collaborative planning, regular feedback to the ministry about implementation, and really ensuring that the ministry was in the driver's seat the whole time. Finally, one thing, as the JSI support is closing in Ethiopia and has already come to a close in Uganda, people on the ground felt that there was a need for ongoing capacity building, support, and mentoring. Some of the practices have reduced or stopped after the project support has ended, although importantly, solutions to the local issues that were developed using those QA tools has continued in many places. Okay, next slide, please. Just to wrap up, a nice testimonial from a health facility manager in Uganda who said this. She said, "I would like to appreciate whoever is behind this approach. Personally, I've seen it is something, personally, it is something that I saw with my own eyes change the status quo. This is an approach that I believe in. It works. It's helped us to think, it's helped us to innovate, and it's helped us to do things better. So, quick summary of the lessons learned. Thanks much, and I'll turn it back to Lisa.
Great, thanks, Steve. And we have, and we'll make sure to have it on our learning group, but a much longer synthesis report. So if people are really interested and want to dive into some of those lessons learned, we'll have that available. So this next slide really is, all of this would be for naught if we weren't able to really have a call to action collectively as donors, partners, countries, and really it's this, recognition that in order to reach 0 dose and under immunized children, immunization strategies really must be tailored to local contexts and needs, and that these strategies must be locally driven and that they must be resourced. And so really our call to action is and ask for really broader engagement and funding of stakeholders to support countries with tailoring strategies for the short term and also for the long term. That there needs to be a renewed focus on building the foundational elements of routine immunization programs, and particularly in weak health system contexts, but that this can be coupled with innovation. There needs to be a greater emphasis on building leadership, management, and coordination abilities at all levels of the health system. COVID-19 has really demonstrated that. And there really does need to be support for innovative approaches to build and maintain these capacities within our immunization teams. So I'm going to stop there, and we're going to switch over to our live Q&A panel session. So I'm going to ask our 3 panelists to join us. So we are very fortunate today to have Dr. Zeno Adam, who is the Technical Director of UIFHS through Improving Family Health Services. Dr. Zeno has more than 30 years of experience in national and international health and has been working with UIFHS for the past 10 years. So Dr. Fossum Daniel, we heard from him at the beginning of the session, is a public health specialist working with the WHO UHC communicable and non-communicable diseases cluster in the Africa region as a team leader of vaccine preventable diseases in the WHO inter-country support team for East and Southern Africa. He is currently the chair of the regional working group for immunization for East and Southern African countries. And then we have Pasi Mujeni, who has 30 years of experience and has played a key role in shaping the immunization program in Uganda. He was at the helm of the immunization program in Uganda for over 10 years and led Uganda to receive a WHO Meritus Award for the best EPI program in 2008. Pasi was the technical lead for implementing REDQI in over 20 districts in Uganda and was at the center of this innovative approach to strengthen RI there. So a big warm welcome to our panelists. Thank you for joining us today. I'm going to ask you each a question. And so we'll hear from each of our panelists, and then we'll ask for broader audience questions. So first one for you, Dr. Zeno. So in Ethiopia, a large focus for the project has been building the routine immunization system in weak health system contexts. What do you think are the most critical lessons learned for achieving success and reaching last mile children in these contexts?
Thank you, Lisa. Thank you, everybody, for your time and attention. Before answering that question, please allow me to, the first 30 seconds, I would like to request the audience as to what the following strategies or slogans sound to you, differences or similarities. A few examples are reaching the unreached, bridging the immunization equity gap, reducing missed opportunities, reaching 0 dose children, leave no one behind. You may choose to use any or all of them, but you will surely arrive at the same destination. To me, they all mean the same thing, and not surprisingly, all are intrinsically embedded in the RED approach and its components. That is what we have been implementing. RED strategy may be decades old, but still is fresh to serve as a solid foundation for global, regional, and national strategies to improve routine immunization. Going to your question, Lisa, in the effort to strengthen, I think, weak routine immunization system, particularly with equity as a center, I mean, as described in the previous two presentations, we have a wide range of lessons, which I will only mention the critical few. The first is the approach itself. REDQI is very simple, adaptable, and flexible design, and which is the model itself is so simple for embedment of innovative approach, and it uses, as described earlier by Steve, it only is based on the existing system that will allow for its capture easily by the existing manpower with little or no additional resources of time, education, and equipment. Secondly, the three-step implementation design that Lisa described earlier was one very highly instrumental to make the difference in broken or weak health systems. As was shown clearly in one of the slides that Lisa presented, it's worth mentioning the following. Understanding the context of this particular area, analyzing the situation and determining the system strength in terms of infrastructure, human capacity, and so on, is very fundamental in implementing. In addition to that, by analyzing the situation, sharing findings with the local authorities and key stakeholders, and involving them in the planning and problem-solving processes were also key strategy for successes in systems of a weak health infrastructure. Furthermore, readjusting the implementation package to match with the system strength so that they can deciding on whether they will absorb the intervention elements of that particular district was also another step that we were working. Based on the findings, building the capacity of the district health managers, health workers at health facility and community health level, integrating skills for both management and delivery of immunization services. And also, as indicated earlier, introducing simple, innovative, and simplified tools for problem identification, analysis, and use of data for decision-making was also the key features of success in poor health systems. In addition, Steve indicated, our implementation starts from the beginning to the end. We bring the agenda of sustainability to the beginning of implementation. So we keep thinking to strategize on how best practices gained during the implementation are kept or sustained in the. So these are the key features of REDQI implementation in such areas, Lisa. The second point is engaging one of the powerful allies of immunization, that is a community. It is something more often said than done, but in our approach, strong community engagement and linkage with the health system is considered as a guarantee for availability and delivery of immunization services to the most vulnerable and hard to reach communities. There are so many experiences to share, but I will only mention two examples in the community engagement. It was also indicated earlier, establishing quality improvement teams or community organs in that particular district or health facility, composed of key community members equipped with new skills of diagnosing the community problem, the fishbone analysis, PDS exercises, with strong alliance with the health system, do play a pivotal role, particularly when the community realize that they are empowered, they are willing to own that role in identifying problems, generating ideas, local solutions to the local problems, and facilitate in defining catchment areas and populations, and involved in activities such as defaulter tracing as well. The second,
So Zana,
yes.
so let me stop you there just so that we can make sure we hear from Fusam and Posse just as we're winding down. But thank you for those contributions.
Okay, then this is one last point. I think the bottom-up micro-planning that was indicated is also a key area because we involve the well-informed and knowledgeable community members in the development of micro-plans, and institutionalization of those micro-plans were the real elements leading to successes in systems with difficulty. Thank you, Lisa.
Thank you very much for those contributions. Okay, over to Dr. Fusam. So briefly, we have about two minutes for you, but so we've outlined how the REDQI approach improved the quality of RI and expanded the reach of services in Ethiopia and Uganda. What opportunities are there to expand implementation of the REDQI approach to other countries and contexts? And then given the current climate, how can we refocus on the importance of RI?
Thank you, Lisa. I will be very short. You referred to the opportunities to expand the implementation of the REDQI approach, and within the given context, how to capitalize to refocus on the importance of routine immunization. I think we need to continue to sensitize and advocate to countries and partners of this excellent approach that have demonstrated improvement of immunization systems to get more buy-in, particularly in countries where local community-based leadership and ownership for sustainability is the priority, as I indicated before, and that partners are urged to support the scaling up of this excellent initiative. And in the sub-region, we have already the equity and the coverage and equity thematic group have already agreed to really lift this high in higher fora so that countries and partners get buy-in and supported. So there is an understanding during the EPI program managers meeting, this to really be again be flagged off and presented. And coming to within the context how to capitalize and to refocus on the importance of the routine immunization, I think during these days we have the Leave No One Behind framework to really continue to advocate for more resources to be allocated for system building in tandem with the COVID-19 response and rollouts, vaccine rollouts. And while we continue really with the opportunities of regular updating of micro-planning to leverage, more resources when the countries work on their annual district plans at the lowest and operational plans at the lowest level. And this should be also integrated with the local needs estimation to secure continuity. And if they continue really work on that one, certainly with all the coming initiatives like the equity acceleration funds, which are coming now from Gavi to really engage multi-country stakeholders, and as well as the humanitarian setups. And I think we need to be including as well the private sector as much as possible, and trying to really convince that the focus should be really more at the lower level, so for the community level. If you can manage that one, I think the routine immunization, the importance of routine immunization and then the system strengthening will be strengthened. over to you.
Thank you. Thanks very much. I know we're in great agreement. Okay, Pasi, so you've supported REDQI implementation in Uganda for many years. What is the most important lesson you've learned about sustaining gains in routine immunization? Oh, looks like we've lost Pasi. Pasi, are you still with us? Oh, it looks like we've lost him. Well, we'll have to have his question be answered through our learning group. And I see we're drawing to a close. So I want to thank all of you for joining us, and a special thank you to our panelists. So Dr. Fossum, Dr. Zeno, thank you so much for joining us. I'm going to hand this over to Liz to just have us have one closing slide.
Great, thanks, Lisa. And I'll go ahead and share my screen again. So like Lisa said, we'll be continuing today's conversation in the Boost Learning group. So you can see we'll make sure all these resources along with today's recording and slide deck will also be uploaded to that learning group as well. So we have a link that I know my colleagues have shared in the chat box. So we welcome you to click on that. We'll also send out the link again in a follow-up email. And also just a reminder to take our brief post-session survey so that we can improve future sessions in the series. I think that's it from my end. Lisa, was there anything else from your side?
No, I want to just thank everyone for joining us. Please do join us on the learning group. We're going to continue to have questions and answers, and we'd love to hear from all of you. And we'll also make sure that we can get some feedback from Dr. Pasi as well. So thank you very much. We look forward to engaging with you all, and we hope you'll join our next session as well. Thank you.
Thank you.
Thank you.
Thank you.